So thanks again to Connecticut Challenge for having me here today. As Sharon mentioned, I have a dual role at Penn. I'm a clinician and a researcher. And my clinical practice, which is about a third of my time, I'm a nurse practitioner, and I see predominantly women with breast cancer, both during treatment, 1 day a week, as well as I have an independent breast cancer survivors clinic a half day a week as well. And then the rest of my time is spent on research and program development in our Livestrong Survivorship Center of Excellence at University of Pennsylvania in Philadelphia, not Penn State. I did have somebody ask me what the climate at my institution was this past week. We are University of Pennsylvania, not Penn State, just to be clear. We're in Philadelphia, not in Pittsburgh. Although I must say, as is the case around the country, certainly what's going on at Penn State has affected us very deeply at Penn as well. But back to the topic of today. These are the things you've been talking about and which you're going to hear from me about in a bit. But first of all, why all the fuss? Why did Sharon ask me to come up here today and spend about, I guess, grand total of an hour and a half talking to you and working with you on the topic of treatment summaries and care plans when most of the other speakers today got 45 to 60 minutes? Why the big deal? Well, I think most of you have seen this slide or heard of this slide already. This is a quote from the Institute of Medicine's report that Mary McCabe referenced this morning, From Cancer Patient to Cancer Survivor Lost in Transition, published in 2006. And as with all Institute of Medicine reports, a number of recommendations came out of this report. So this report specifically focused on adult cancer survivorship, defined in this report as that time period following the completion of acute treatment. And of the 10 recommendations, recommendation number 2 has been the one which has gotten the most attention, and that is the recommendation to provide a treatment summary and care plan. So that what it stated explicitly was patients completing primary treatment should be provided with a comprehensive treatment summary as well as a follow-up survivorship care plan that is clearly and effectively explained and includes these broad categories of things. What did the patient get? What complications were there from that treatment, and what can be expected in terms of potential complications or consequences, including long-term or late effects, information and education about those consequences, then follow-up care. How should that look? What is needed moving forward, and what testing should be done, and then also resources and referrals to help support the survivor. So this is really a broad strokes description of what that treatment summary and survivorship care plan should be. If you go to, I think it's page 154, this box 316, maybe it's 152, I've referenced this so many times. This is in the IOM report, and this is the more granular version of what I just said. So what you see here is that the IOM said a number of things should be included in the survivorship care plan, which if you look at it, it can be a bit overwhelming. How do you accomplish information about all of this in one document? Okay, part of what we'll talk about today. Now here's the real kicker, is that this is now, as of 2015, if you are an American College of Surgeons Commission on Cancer accredited institution, this is why all the fuss now. By 2015, you are going to have to meet the standard of delivering these treatment summaries and survivorship care plans to patients at your institution. What that particular standard says is the Cancer Committee develops and implements a process to disseminate this comprehensive care summary and follow-up plan to patients with cancer completing cancer treatment. And the way they define a survivorship care plan in terms of its implementation is that this really needs to be done by the principal providers or provider group who coordinated the oncology treatment. It's given to the patient on completion of treatment. We can have some discussion, as I already had at lunch break, about, well, is at the end of treatment the best time to first introduce this? My opinion would be no. We should introduce the concept earlier on to make it at the end of treatment more feasible and among other things, the patient needs the information prior to that time point. But this is what the Commission on Cancer is going to hold institutions to, is at the end of treatment, that it should contain a record of care received, important disease characteristics, and a written follow-up plan. And what the COC says should be the minimum standard is that, what the IOM defines as being included in that survivorship care plan, which again is a comprehensive list of things. Now, is the COC by 2015 going to be having a checklist of all these things on this page and saying, did you address X, Y, and Z? Or at that first pass of, are you meeting this requirement? Is it really more going to be about the process being in place rather than the particulars of the document? I don't know, but what I'm hoping to have you all feeling much more confident about doing when you're leaving here today is getting both pieces of that process well underway at your institutions. First, getting that process of delivering the treatment summary care plan ingrained in your institutions, and then the second piece, feeling more comfortable that you can actually address the vast majority, if not all, of the content that is requested. How would that feel if you left today feeling more confident about that? That feel good? How many of you feel confident about doing that right now? Raise your hand. Okay, so we have a couple people in the room. Good. We will definitely be calling on you later today. All right, so clearly there is a consensus that we should be doing treatment summaries and survivorship care plans. But why? Why has this particular recommendation of the IOM report really taken such root and really taken on a life of its own, and now this COC is only one body that's requiring them. If you are a Connecticut Challenge supported institution, you're required to be having this process at your institution as well. And then the NCI's National Community Cancer Centers program, I believe, has that as a requirement as well, that treatment summaries and care plans be delivered. But why? Let's just step back for a minute and talk about that. You've already seen this slide from Mary McCabe earlier today, that now there are 12 million plus cancer survivors in the country, so we really need to be meeting their needs. How are we doing in that regard? So let's talk about what is survivorship care. You heard a bit about this in models well, more than a bit. You heard a very comprehensive and thorough lecture from Mary McCabe this morning about how to deliver survivorship care, what some models are. But let's step back for a minute and talk about, as a country, how are we doing in that regard thus far? So when the IOM report talks about survivorship care, they are talking, as I mentioned already, about this particular period in the gray box where the patient has completed their treatment with intent to cure and now is in this cancer-free survival or managed chronic and intermittent disease period. So that's what we're really talking about with survivorship care. And the IOM said there really are 4 elements of survivorship care. Prevention, so prevention of new cancer or recurrent cancer and of other late effects, so prevention of lymphedema as an example. Surveillance, looking for cancer recurrence, second cancers, and looking for long-term effects like menopausal symptoms or I always use breast cancer analogy since that's my practice, but in the prostate cancer population, genitourinary problems, are we screening for these things? Intervention for these consequences, including symptoms and medical and psychosocial problems, and then a biggie with 12 million cancer survivors in the country, coordination of care, who's doing what, how are we managing the care of these individuals, especially as you heard Mary talk earlier today about the fact that we're really going to be hitting a workforce crunch here, that the number of cancer patients and survivors in our country is rapidly overtaking our capacity in terms of oncology physicians and nurses and other providers to care for them. And we have to be thinking about how we can partner better with primary care. One thing I just noticed people switching or flipping pages in the syllabus. I did change up some of my slides. The overall flow is pretty much the same, but don't get confused if what you're seeing on the screen is not exactly matching in the syllabus. So how are we doing in terms of these 4 goals? So the first 2 were prevention and surveillance of both cancer and other late effects. Well, we know we're not doing that well yet. One of the challenges, there's limited availability of guidelines for late effects. So for example, do we screen every person who got adriamycin for breast cancer with an echocardiogram? Well, no, that's not currently something that is believed to be necessary or helpful. For late effects, there are not really many well-established guidelines. There are for others, though. So bone health, for example, we now have bone health guidelines for breast and prostate cancer survivors saying if they're on certain therapies, should be getting DEXA scans X frequently, et cetera. But we have a lot of work to do there in terms of the evidence base for guidelines moving forward. Even in areas where we have evidence, we know that surveillance guidelines are underutilized and with disparate outcomes. So for example, did you know that some populations of cancer survivors have actually been shown to get less non-primary cancer surveillance tests? Like the example would be a colorectal cancer survivor not getting a mammogram, a 55-year-old colorectal cancer survivor not getting a mammogram, whereas a 55-year-old female who hasn't had colorectal cancer gets that mammogram. So that cancer survivors tend to get less either non-index cancer surveillance or non-cancer surveillance, so less lipid screening, that sort of thing. So what our survivorship care plans need to be doing as well is not only focusing on surveillance for the primary cancer, but also for other cancers and for non-cancer problems. So how are we doing with intervening on consequences of cancer and its treatment? Again, we know we've got a lot of room to move here. We know that secondary health problems are prevalent and under-addressed, including symptoms, and survivors have very little knowledge about treatment's inherent risk. We talked about that this morning with these, on a number of occasions, people not knowing what treatments they got years later. How do they know what they're at risk for if they don't know what treatments they got? The young adult survivor population, perhaps even above all, if what Jennifer Ford had to say earlier today is true. And that's really an issue not only post-treatment, but during treatment. We had a very vigorous discussion at my lunch table about how when patients get admitted to a local hospital, they have no recollection of what treatment they're currently on, let alone, you know, if they're a survivor 20 years later, what they got. And the Lance Armstrong Foundation has done a nice series of surveys to identify what are some of the undermanaged or unmanaged problems of cancer survivors, flipping back to that first bullet point in terms of we're not intervening well. So in their study of over 3,000 post-treatment survivors done on the web last year, 98% of these greater than 3,000 survivors said they had at least one problem that they attributed to cancer. How many of you are surprised by that? No one's surprised, right? We know that going through cancer has lasting physical, psychological, social, financial effects. 86% of them said they had at least one physical problem, and the top four were fatigue, concentration, sexual dysfunction, and pain, including neuropathy. Surprising to anyone that these are the top four and that people are experiencing these? No. Emotional concerns, fear of recurrence. Mary McCabe said earlier today, probably 100% of people nearly experience that. Depression, grief, identity issues. The video that Jennifer Ford showed in the young adult population, I think, did an exquisite job of painting what some of the emotional concerns are in the young adolescent and young adult survivor population. And then practical concerns, same thing. More than half of the survey said they were experiencing these. Here's what's really provocative about these data. We know that survivors are out there experiencing these things, but are they getting care for them? And this is what was striking about the report, is that only 58%, so greater than 40% of patients experiencing physical problems said that they got care for them. And for those top four, sexual dysfunction, the taboo topic, fatigue, concentration, neuropathy, pain, less than half of cancer survivors received care for these issues, okay? And emotional concerns, only half. Practical concerns, only 20%. We are really falling down in meeting the needs of survivors, at least recognizing that this is perhaps a bit of a biased sample because this was people responding to a web survey, but I think the message is clear that we need to be doing a better job. If they got care, they said it was reasonable care and it met some to all of their needs, but for that vast bulk of people who didn't get care, Why didn't they? Think about the attitudes behind this. They said, I learned to live with it, depending on what the kind of problem was, emotional, physical. It was anywhere from a quarter to over half. I addressed it on my own, or I was told it was a side effect. So basically themes of acceptance, that this is what it should be, or I learned to live with it on my own. I wasn't able to get the help I needed. So it's was a real wake-up call for me seeing these results from the Lance Armstrong Foundation survey, saying we need to be doing a better job of organizing services for these patients. Just briefly, some of our own work at Penn, June Miles, one of my colleagues, we surveyed 300 breast cancer survivors, and getting to that point we said earlier about people not knowing their treatment, we actually did research on this. So these were 300 breast cancer survivors. We asked them to report what their diagnosis details, like ER, PR, estrogen receptor, progesterone receptor, et cetera, what chemotherapies and radiation they received, et cetera. And then we also asked them questions about how confident they were in managing their survivorship care, so managing their risk following cancer treatment, communicating effectively with healthcare providers, seeking appropriate information. Here are our results. Although their overall score in terms of their knowledge about their cancer and cancer treatment was, in effect, a C, a 74 out of 100, barely over half could correctly identify all their cancer chemotherapy treatments. And again, that's an issue. So if the 60-year-old woman is presenting to the emergency room with complaints of shortness of breath 10 years after her adriamycin Cytoxan chemotherapy, it's really important to know that she could be experiencing delayed cardiac toxicity from anthracycline, or if she's presenting even more so in her primary care physician's office, right, with subtle complaints, less dramatic. The primary care provider has to know that she's gotten some adriamycin exposure to be thinking, oh, could this be adriamycin-induced cardiac toxicity? And the other striking thing from the study was that where women felt that they were not as well informed about what to do about their health risks as a cancer survivor. In terms of coordination, we know that care is fragmented around this country, that it's not clear who's doing what. So usually you at least know if the patient is happening to still see that oncologist, that the oncologist is probably screening for that primary cancer recurrence, doing the mammograms or doing the colonoscopies or doing CAT scans if it's a lymphoma patient. But who's doing the rest of stuff? And how many of you have talked to your patients who are cancer survivors or your clients if you're in an agency that helps to serve cancer survivors and they say, well, I don't have a primary care provider. Why do I need one? I see you for my cancer, or I see my cancer doctor for my cancer. Those other non-cancer health needs sort of get down prioritized. So that's another issue to grapple with, and our workforce trends are really going to exacerbate that situation. So the consequences of all of this that I described is that unmet and undermet needs are going to continue, and cancer survivors themselves will increasingly shoulder that burden of navigating ongoing care and communicating needs. And what you've seen from the Livestrong, the Lance Armstrong Foundation survey, is that they don't feel empowered many times to do that yet. There's instead this culture of acceptance. Okay, this is what's to be expected. I'm not sure what to do about it. I'm not sure what help I can get about it. And that's where I see survivorship care plans really coming into the mix to try and help address some of these gaps. So that if you give patients a document about what they received for treatment and what to expect, and give them a library of resources that they can access if needed, then that helps to take away that impression, that culture of this is accepted, there's nothing that can be done, and helps mobilize and connect them to resources. In terms of what do we know about survivorship care plans so far, are they effective? There's been very little research yet. The biggest trial to date was published just 2 weeks ago. How many of you saw Eva Grunfeld's clinical trial in the Journal of Clinical Oncology? Anyone? So this is the first big, large-scale study of survivorship care plans, and I bring it up here because it's just that. She looked at 400 plus breast cancer survivors in Canada. This was what's called a null trial. It actually showed no impact of survivorship care plans on their chosen outcomes. But there are a couple key points to remember from this study. If you hear about this, and if your administrators at your institution say, well, why are we doing this? The only big study that's out there about this showed it didn't have any effect. Well, what she did was, first of all, this was a Canadian study, and the context of care is very different in Canada. So it's actually, in many of the provinces, quite typical for X months, 18 months, 24, 36 months after diagnosis, breast cancer survivors get transitioned to primary care, and they get a discharge visit with their oncologist in order to facilitate that and make it clear that now the care is being transferred to the primary care. So in this study, that was the control arm. The intervention arm added a 30-minute visit with a nurse who delivered a treatment summary and survivorship care plan. So one thing to know is that already the control arm pretty much was an intervention we don't do here in the U.S. How many of you, when a patient leaves your institution, do you have a formal discharge visit saying, okay, your care is transferred to primary care now? Does anyone do that? So the context is very different. And then, interestingly, some of the outcomes she chose in this trial really were around cancer-specific distress and overall distress. So are you depressed? Are you anxious? Do you have intrusive thoughts about your breast cancer? Outcomes that really weren't well tied to the survivorship care plan that was created. This was a survivorship care plan really focused on the follow-up care, who you need to see, how often, et cetera. So there are a number of limitations with this trial that I just want to make the point of calling out to you, so if others discuss this trial with you, you have a good handle on why perhaps it didn't show benefit and that more research is needed. Some of the earlier pilot studies, so Kevin Offinger at Memorial Sloan was mentioned by Jennifer Ford this morning. He did a really neat thing. I think one of the key points I want you to leave with today is that the perfect can sometimes be the enemy of the good. So I mentioned that the IOM has this whole list of recommendations, and if you try and meet all of them as your first iteration, you may never get off the ground. This is a brilliant example of using sort of a more focused survivorship care plan. What Kevin Offinger and colleagues did is took Hodgkin's disease survivors who are at increase for breast cancer. You heard that statistic earlier. I think it was something like 58% of the young adults and young women in Jennifer Ford and Kevin Offinger's study weren't getting mammograms even though they were at risk, right? So they did an intervention to see if giving a mailed care plan that basically said you're at risk for breast cancer, you're at risk for cardiac toxicity, go get your mammogram, go get your echocardiogram. That was what their survivorship care plan was consisted of in this study. And what they saw is that in this population where none of them had gotten it prior to getting this care plan, then 6 months later, 41% of that group had gotten a mammogram and 20% got an echocardiogram. So a very simple, focused survivorship care plan around a particular topic really improves surveillance behaviors. Some of the other work that's gone on pilot study-wise around the country, this is similar to the model we have at Penn, where at Michigan there's an NP-led survivorship visit, and this showed high patient satisfaction outcomes, a reduced number of patient concerns. So patients, when they came in, were asked, what are you concerned about? Nutrition, bone health, what your follow-up care should be, coordination of care, and then looked again several months later, and those concerns or knowledge gaps had dropped down. And people expressed they were feeling more prepared to manage their health care after this clinical visit. And then finally, in Australia, again, a very small pilot study of just 10 colorectal cancer survivors who sat down with a nurse navigator at the end of treatment and then got 3 follow-up phone calls, and this decreased unmet needs and improved satisfaction. So that's a lot of background. Now we really need to talk about the meat of how do we do this. And this is where we'll also integrate many of your perspectives at your institutions. So above all else, there is no one-size-fits-all approach. So you're not all going to be leaving here today with the same template and the same answer. You are not coming here with the same template and the same answer. And how survivorship care plans are actualized at your institution are going to look perhaps widely different from one place to the other, but we can also learn from one another. So in terms of that who, what, where, when, why, how, I do want to learn somewhat about your exemplars. The way I'm going to approach this didactically today is also talk about how we've approached it at Penn, what some other exemplars are I've learned about from lecturing around the country on this topic. Make sure you're aware of ongoing and planned efforts that are going to facilitate this for you. I think one thing that's very important to recognize is, okay, so the Commission on Cancer is going to require this, right? Some people feel very nervous about that. How am I going to get this done? The one thing I would say, though, is that where standards come in, then institutionally, often, that will create a garnering of resources in that direction. So that from what I've seen from reviewing many of the emails I got from centers around Connecticut is that, oh, I'm a one-man band, or we're just two people at this institution trying to do this. We need more resources. The piece of hope that's tied to when it becomes a larger standard is then institutional administration has to become part of the discussion about how they're going to meet this standard. And hopefully you will have more partners to play with in the years coming ahead. I'll also talk about some of what the Commission on Cancer themselves have talked about in terms of facilitating this effort. They recognize that they can't impose the standard in isolation, that they actually have to help with some resource development to make it a reality. So first, what I wanted to ask is, and we're going to keep this time kind of fluid. I know we have until 2:15 is didactic and then another half an hour for discussion, but I'd like to keep it kind of fluid if we can. What I'd like to hear about is, from the discussions you had at the end of lunch, what are some of the novel things that you heard from somebody else at your table, or conversely, if it was something you learned was novel of yours because nobody else was doing it at your table, what are some of the novel approaches to survivorship care plans that are going on now? Sorry, Sharon, I didn't warn you that you would have to be hopping up and getting the mic. Anybody want to share something they learned today that they thought was pretty novel? Okay, you got your first one over halfway down the, what's for me, the left side of the room.
Yes, I learned that Middlesex Hospital has nurse navigators, and that they also have an integrated team approach to their outpatient care. I'm looking at the woman who, I'm sorry, Lisa. And they have a naturopathic physician on that board. So I was quite pleased to hear that. And thank you, Lisa, for sharing with us.
They have a what position on the board?
Naturopathic physician.
Oh, a naturopath position on the board. Excellent. Okay.
Okay. Hi, good afternoon. I just wanted to, as I was listening to you speak about the whole survivorship plan, we at Bridgeport Hospital were recognized by the ACCC just recently for our patient passport. And we have a couple of copies here, and it's probably one of the easiest ways to start your survivorship plans at the grassroots level right now, because I think our goal is to become electronic moving forward, but if you, certainly I'll share it. But if you want to review it and the pieces and components of it, that really makes life much easier. I'm speaking for my team, who really are the folks that go out and fill this out, but again, we have nurse navigators, our physicians, our social workers, everybody works collaboratively to complete this once the patient starts their journey with whoever they're working with. And to your point, if you wait till the end of their treatment, it's way too late, because half the time you've forgotten or things get missed. So we try to start this right away so that we have all of the information from the beginning of their cancer journey right through to survivorship and their surveillance plan.
Excellent. Do you mind if I keep it up here for a minute? Keep it. I'll get back to you. That's good. So I want to follow up on that thread. I was hoping somebody would kind of jump up and share that type of approach. So I wasn't familiar with this until it was just handed to me. Thank you very much. But this passport is basically a small booklet, from just flipping through it real quick, and from what you described, is a small booklet that is given to patients at the beginning of their treatment or around time of diagnosis, and then places some of the onus of creating that treatment summary on the patient in partnership with the clinician. So that instead of at the end, we had a conversation back also at, I'm forgetting what hospital, Jan? Greenwich Hospital, that they are revising their approach in a similar way, that perhaps it's not a booklet, but they're starting with not a laminated, but a sheet that goes into, a sheet of paper that goes into a plastic sheet that the patient then populates over time. And the Institute of Medicine held a entire conference on this very topic earlier this spring about treatment planning, that what we should be talking about is not just survivorship care planning, but planning of care from the time of diagnosis, so that patients know what they're receiving, what the roadmap is during treatment, and then the survivorship care plan just becomes a natural extension of that. So this to me is really a movement of survivorship care earlier on in the course and tying it to treatment planning.